Great. It's now my pleasure to introduce the two leaders for the two sets of pilot sites that have really done yeoman's work as far as overseeing the implementation, and they're going to talk about care processes and the pilot experience. The first is Dr. Ken Sands, who is the Senior Vice President of Healthcare Quality at BI Deaconess Medical Center, and one of the pilot sites for the care implementation. He's an Associate Professor of Medicine at the Harvard Medical School, and Dr. Sands has research interest in patient safety and complications of hospitalization, with particular interest in prevention of healthcare-acquired infections. His more recent interests have been in the detection and prevention of non-infectious healthcare-related adverse events, healthcare systems improvement, healthcare liability reform, and performance improvement education of physician trainees. And Dr. Evan Benjamin is Professor of Medicine at Tufts University School of Medicine and the Sackler School of Graduate Biomedical Sciences, as well as Senior Vice President for Quality and Population Health and Chief Quality Officer at Bay State Health in Springfield, Massachusetts. He is a board-certified internist, founded the Division of Health Care Quality at Bay State in 2000, and has helped to create the Center for Quality of Care Research in 2006. His work has helped to transform healthcare within the three-hospital Bay State healthcare system, garnering a number of national awards, and has been a model for other healthcare organizations. So they are really going to talk to you about the nuts and bolts and the nitty-gritty and some of the lessons they've learned in the first year and a half of implementing care at these 6 pilot sites. Thank you, gentlemen.
Good morning. I'm going to start things off, and thank you, Alan. And my job is to describe to you why, as a physician in a provider organization, we got into this business, and what was some of the information we had from those that went before us. And then Evan, I'm going to hand it over to Evan, who's going to talk some about how we've set up the pilot sites specifically. Let's see here. Am I going the right way here? Going backwards? Here we go. So it was clear to us, as this field has been developing in Massachusetts, that we felt like we could do better than the traditional liability system, which many of us are familiar with from our past training. Something goes wrong, pretend nothing happened, give as little detail as possible to the family, use the so-called deny and defend strategy. If there was a true error, try to reveal as little as possible to the family or the patient, and that this was the strategy felt to be most effective in avoiding liability. On the other hand, there's clear data going back to a position statement from Senators Clinton and Obama back in 2006 when they were advocating for funds to help with liability reform. The patients, what they're really looking for is some kind of more effective communication than they have received in the setting where there's been an adverse event, and that it is a lack of empathy and that perceived withholding of information that truly drives the liability experience. So we've moved into a space of communication, apology, and resolution, and that's our preferred language as part of this program, with the principles really relating to those words that we feel like communication is the key, and that should be clear, empathic communication with patients and families whenever an unanticipated adverse outcomes occurs. Investigate and explain what happened, and then implement systems to avoid those recurrences in those cases where those recurrences were felt to be preventable. Where appropriate, apologize and offer fair financial compensation without the patient having to file a lawsuit. The principles of our care program is to compensate patients quickly and fairly when unreasonable medical care caused injury. So we are interested in being fair and fast with this program. If the care was reasonable or did not adversely affect the clinical outcome, support caregivers and the organization vigorously and still communicate with the patient about this information. And that all of this will reduce patient injuries and therefore claims by the learning, and that's really where the important part of this comes in, is the opportunity for more learning. We are not the first folks to stumble into this arena. We have folks that have gone before us as the real pioneers. We're lucky to have some of these people here and to have been guiding us through this program in the last couple of years. The University of Michigan's program, led by Rick Boothman, the Stanford program, led by Jeff Driver. Jeff was a speaker here at our forum last year. And then there are several other programs working currently with AHRQ, putting pilot programs in the field as well, apart from our program. And we are very lucky to be part of a study with Harvard School of Public Health looking at liability effects and implementation in Massachusetts. And you're going to hear more about that later today. Here's the data from the University of Michigan, and some of this is familiar to you. It's been published by Alan Kachalia and others. Alan's another person who's been key to our rollout of this program. Alan's now at the Brigham and Women's Hospital. But the experience over 10 years at the University of Michigan, presented here as before-after data, is a dramatic decrease really in all kinds of claims, but particularly lawsuits as the most significant change, and that's the graph on the left. The graph on the right showing that the cost of the program overall went down, while at the same time the percentage of funds reaching the patient went up. So what you have is a program that's more effective, and when compensation is appropriate, more of that overall spend of the program ends up actually as compensation for the patients. So these are the outcomes that we've been seeking to emulate. Stanford, we saw this data last year from their Pearl program, how they have put something very similar into implementation phase and have been able to study it over several years and have shown dramatic reductions in cost of the program overall. They've seen lower frequency of claims and a pattern moving towards faster closing of claims, although their data is still a bit premature in that respect. But overall, they've been able to save millions of dollars in their claims program and have been able to return those funds to their physicians in the form of lower premiums. So I'm going to tell you about a case from our own institution, which we've felt to be instructive as illustrating some of the principles that we've come to hold close as part of our implementing this program. And this is a real case, although not a real name, but we'll call this Mr. Nagashi. And this was an individual who called patient relations at my institution to voice a complaint that he had seen his physician, had had blood tests drawn, and then never had any follow-up on those blood tests. In the meantime, he became very ill and had to be admitted to the hospital. He had to go to the emergency department. He ended up being admitted to the ICU and received a new diagnosis of diabetes. He'd never had diabetes in the past. This was a new diagnosis for him. He actually had a short ICU stay and then a hospital stay. He missed work. He had some vision problems, which it's not clear whether they are permanent or not following this hospitalization. So there was a financial impact to him in terms of his inability to work for several weeks, as well as the entire inconvenience and stress of having been in the hospital. He calls our patient relations department to notify us of a problem, and you have the distinct feeling that when he hangs up the phone, he's ending the relationship with our institution. There's no sense that he's planning on calling us back, that he is litigious. He's simply doing what he feels is his duty to let us know about a problem, and then it's done as far as he's concerned. We review this case, and we find that, in fact, this was a patient who had had a hemoglobin A1C diabetes test drawn several months earlier in our clinic, was told to come for follow-up. He did come for follow-up. It was at that follow-up that he had another test drawn, which was extremely elevated. That was the test for which no report was given to him. He actually called our clinic a couple of times, the specific clinic where this happened, and had and requested the results. No physician returned to him, And it turns out this clinic did not have a solid closed-loop system for making sure that test results were returned to patients and that there was a reconciliation about those calls. Our peer review confirmed that our standard would have been immediate follow-up for these kinds of lab tests, and that didn't happen, and that was our responsibility, and that there was a causal link between not having followed up on that test result and the fact that this patient had to be admitted to the institution. So this gives you something to chew on while we're talking about how we have actually implemented things at BIDMC and our affiliated hospitals, as well as Bay State and their affiliated hospitals. The way things work in action is that we have algorithms, very specific algorithms that we use for applying care in each case. We use our internal patient safety and risk management program to implement the program. We work very closely with our insurers to attempt early resolution if our cases meet criteria. And we educate our staff and facilities about the merits of care and the action steps. So there's a very powerful initial education phase to our programs, and then I think we've really found it's a matter of ongoing education to keep the program active. And we've been convening as a set of pilot sites to discuss our work together and learn from each other's challenges. And I'm going to hand it over to Evan to take you through some of the specifics.
Good morning, everybody. You know, I think the biggest benefit of really creating the alliance has been for us to come together as a group to really learn best practices, to establish those best practices, and to talk through the many challenges that we've seen in implementing a program which, while not necessarily new, creates all sorts of learnings as we go along. So the sites that we have initially, there were 6 pilot sites. There were the 3 Beth Israel Deaconess Medical Center sites, so 1 large academic teaching hospital and 2 smaller community hospitals, the large Bay State Medical Center site, an academic medical center, and 2 smaller rural hospitals. And there's really a nice mix in those 6 there of between the teaching hospitals, between the locations, as well as in the rural sites. We have a mixture of our medical staff that are involved with both a central captive insured group as well as community insured group, mostly through Covera. So we were able to have the experience of both. And you see in the bottom there the addition of Atrius and Sturdy, as Alan had mentioned, is really going to really round out the full experience. But you know, if we look at what we've done, you see in those best practices that Melinda had mentioned, there are a number of different best practices there, and if you take a look at the ones around how to interface with patients and how to establish, in your packet there's also 2 algorithms. And what we've done is we've tried to create standard work around these algorithms. The algorithms really start with, the first is an algorithm that filters the case and really asks the question is this case a potential care case? And it's actually very simple. We're asking 2 basic questions. Was the standard of care met in the case? And if no, was the standard of care, did it contribute to harm? The second protocol is really the full care protocol, which is going through the insurer process. So the first filter, and we just pulled out a section of it here from the full protocol in your packet, is really focusing in on these 2 questions, the standard of care, and if the standard of care was not met, it contributed to harm, then the case would make it through the filter and be referred to the care insurer case protocol. The insurer case protocol is really now when the case is being fully reviewed by the insurer. So they're having input from the facility. And the process at the facility through the peer review process, through internal reviews of what happened in the case, But at that time, the insurer is then taking the case and really making the final decision about an assessment of fault and the attribution of fault, as well as the potential compensation. And so it's at that point that after the insurer has reviewed it, that a meeting is set up with the patients and the family and the patient's attorney to begin the process of really completing the apology, the communication, and then the resolution with the offer of compensation. The Care Insurer Protocol in your packet really highlights a few issues. After the communication, apology, and resolution, there are a number of different options of how the resolution can evolve. One is that the patient actually does not desire compensation. And we've actually had many cases like this where we've had the communication and the apology, and it's really not compensation, but other means of resolution that the patient and family really wanted to talk about. They wanted to be part of the solution in terms of how do you prevent this from happening again. They wanted to be part of communication and education to providers, but really not necessarily compensation. The other path is that an offer is made and it is accepted by the patient and the family, and the case comes to conclusion. The other two is that the offer is actually rejected. And there's two paths that we're starting to see. The offer is rejected, and we actually don't have any further follow-up from the patient and family. And depending on where the patient and family is and their emotional state, we have many that are still sort of in that sort of nebulous follow-up period. And the other is that the offer is rejected and a litigation ensues. Now, what we're learning is this timeline is very rough. In our experience, while it is a general timeline, we're also seeing that every patient and every family is unique. In the best practices around how to interface with patients and families, we mentioned specifically about the issues of meeting patients where they are. And that timeline is very unique. From some patients who actually can't even engage in any discussions, that there's actually some serious trauma associated with the event, and they're just not ready to even go there. Others where the event may be, depending on the seriousness and the harm, ready to talk immediately about resolution. But in general, the timeline looks something like this, that within the first 24 to 48 hours, where our patient safety staff is involved, we're mobilizing support services, and we're having initial discussions, usually with the providers and the patients, talking about what happened, what's known, what are the facts. Within the next 2 to 4 weeks, the internal investigation is taking place, and we're trying to move that faster so we can get through that first protocol within those first 2 to 4 weeks. So at least we have an internal understanding of what happened, the near completion of a root cause analysis, as well as the initial screening protocol of was the patient harmed, was a standard of care met, and if the violation of that standard of care contributed to harm. By 3 months, the internal investigation and the full root cause analysis is complete. And then if, in fact, it has gone through the filter, it is really then handed over as an insurer case where the insurer is now involved, looking at the case, beginning to attribute fault, looking at the value of the case, and then reviewing the implications for compensation. It's within really 3 to 6 months that the initial meeting is then made, and if things have gone well, if we are closing these care cases within 6 months, we're actually quite pleased, including that final offer being made and then accepted. It's that timeline, which I think is really what we're seeing from our providers, is they're getting on board with care more and more, because if after a significant event, if it is resolved within 6 months, it allows people the peace of mind to begin their own healing. So both on the patient side and the provider side, we're seeing that if we can do it within 6 months, you're really seeing the beginning of the healing process on both sides. So what do we tell our clinicians? A lot of this has been evolved over time. In our best practice protocol, we share sort of 4 steps. This is just data from the University of Michigan, but it's really around the issue of reporting. And you've probably recognized that for this to be successful, a culture of safety really needs to be intact within the organization, and that really open discussions about near misses and medical errors already needs to be in place. So the first step is really having everyone report mistakes and report medical errors. So it's not until we actually have that level of increased reporting can we begin to even have the conversations about communication, apology, and resolution. So we tell clinicians, first of all, report things and have the openness to begin those discussions. The second step is really around then the communication with the patient and family about the event. It's very difficult to train a couple thousand providers in an organization. So most of this is done through general awareness that there is a communication process, and then it's really sort of real-time coaching, that the communication to the patient and family is about what are the words that are being said. And the words are really around expressing empathy and expressing this regret about the event, and not necessarily within those 24 to 48 hours, the apology. We really talk about the apology later when we really understand the facts. And in fact, sometimes the whole program has so much awareness in the organization. People move very quickly to apology, and sometimes we actually have to slow things down and say, initially, it's really about regret and the facts, and that's probably the safest thing to do. The third step is really just around documentation, what was said to the patient and family, make sure that the facts were clear, what was said at that time, what were the facts that were known. And then really the fourth step is around a consistent approach of checking back with the patient and family to discuss the findings. If you go back to that timeline I showed you, within those first 1 to 3 months, as the root cause analysis is complete, if the facts are known, even before you're getting it into a insurer protocol where the discussion then more is about resolution. And the consistent approach around that checking back in is making sure there's a single point person in the organization, whether that's patient relations or in patient safety or in risk, but that checking back in with may also include the providers, but it needs to be a well-coordinated approach. So a number of challenges that we've seen. You know, it sounds wonderful as we lay this out, but we find that some people really don't want to engage in this. And some of it is a matter of timing. Some of it is a lot of anger. Some of it is the level of communication that they've had to that point. The better we are about the event initial discussion, the better the opportunity for engagement is. But still, not everyone will engage. The issue down the road when we get to resolution is this discussion about value of the case. Sometimes there's some very unrealistic expectations of value. And so getting an agreement around the value becomes challenging. As we put this in place, we've recognized it really has become sort of a fundamental change of how we looked at errors and how we looked at our peer review process, and needing to do more in-depth investigations faster also was another challenge for the organization. And so really having these internal investigations and then as necessary external investigations, but to do that in a timely fashion. And finally, as Alan had mentioned this morning, you know, the providers are still worried about the reporting, and we don't have resolution on this, both to the Board of Registration in Medicine and to the National Practitioner Data Bank. We're trying to follow a lot of, I think, what Rick Boothman's done at the University of Michigan. And if, in fact, our investigation shows that these were system-related issues, We're trying to say that these were institutional issues and not individual issues, and therefore, until we have more clarity from the National Practitioner Data Bank, we would actually not necessarily be reporting an event associated with a provider if in fact it is a system issue. So a lot of issues around that, but the providers are still worried about it. So let me come back to invite Ken back up and finish the case, and then we'll have a lot more time for discussion in the Q&A.
Thanks. I'll take you back to how this case was resolved, and then I'm going to talk a bit about what we've learned qualitatively as part of our care process, and then we're going to move to Dr. Mello, who's going to talk about what we've been learning quantitatively about this project. So Mr. Nagashi, we didn't think we would hear back from him unless we called him, which we ended up doing. This is I think new work for an institution like ours since we started the program to be doing this level of reaching out. But we did give a full explanation to what we learned from our peer review to Mr. Nagashi. He received an apology, and it was decided that compensation was appropriate. He had had some losses, and that compensation was based on expenses encountered, lost work, pain, and suffering. That payment was determined and made by the hospital's insurer on behalf of the hospital and the physician. Here's the somewhat tricky part, and that is that there was a reporting to the NPDB in association with a decision that apportionment of this case was felt to be 50-50. We felt that there was a systems issue relating to the performance of that clinic and not having a strong closed-loop system for following up on labs. And the physician involved readily endorsed this analysis that his expectations for following up were not met. His expectations as a professional were not met in terms of how things were designed to work in that clinic. And so there was apportionment to the individual. Our interpretation is that generates an NPDB report, which is what happened. How did the physician feel about that? Well, no physician wants an NPDB report, but when asked whether he would rather this be resolved and settled in a 5-month time frame, which is what it took in this case, as opposed to having something nebulous hanging over that physician for 5, 6, 7 years in terms of whether this was going to become a lawsuit. He felt that emotional toll would have been a much more significant event for him. We did implement a closed-loop system in this practice, and this case was shared in multiple forums in our own institution. So we have been able to use it for learning, which is really the goal in this case. So we're learning a lot. And let me just tell you about some of the main things that I think that all of us in the pilot sites have been finding. First of all, that it's really all about communication, and I'm sure that surprises no one in the room. But in cases like these, it's all about the communication and getting to a place where people have a common understanding of events, a common understanding of what the loss was, and what it takes to fully resolve that loss. And that resolution might involve compensation. It might involve an understanding of what's going to happen in the future to prevent further cases, which is often equally important to folks. It's about having the right skill set to make that communication, being able to express empathy appropriately, making the commitment to follow up in building that relationship and that trust. That actually is a big part of the healing. Sorry, these buttons. Either button I push is taking me backwards. Oh, the wheel. Okay. Sorry about that. Which way am I going now? Okay, here we go. All right, good. Thank you. So that was a quick review for you all. So Getting clinician buy-in is the other thing that all of us have found were key. I mean, there's an enormous amount of trust that one has to have with one's physician community in order for this to work. That involves creating trust with the individual physician that you're working with around a case, the other individual clinicians that might be involved in a case, and also trust in the system that has been put in place to do this as an institution. I think all of us who are involved in these pilots have put an enormous amount of energy into having the patient safety and risk management program in place that our clinicians feel comfortable engaging with in order to pursue this kind of initiative. Communication with patients is never easy. This is something that to some degree you can teach ahead of time about core principles, but it's also always in the moment important to have some way to support clinicians in the nuances that might be part of a communication in the moment. So we have in our institutions set up ways to have coaching available 24/7. We have page numbers that people can call. We have ways of either on the web or on cards attached to IDs to make sure people have that information so that support can be given in ready fashion. And we use the 4 simple steps that Evan reviewed in terms of making sure that people have a simple framework for that communication. Some of the lessons we've learned at the pilot sites is that care principles and processes have to be reinforced daily. So this isn't something we feel like we're pursuing simply when a case occurs. This is something we're talking about on a regular basis. I think it's becoming part of the fabric in terms of how we talk about our relationships with our patients and how our clinicians approach care. There's this issue of, are you already doing it? I heard myself saying this several years ago. If there's clear harm, you should just settle these cases up front. Well, yeah, we kind of do that. I think all of us have found that there's a big difference between telling yourself that you sort of do that and that's the system you're working under versus really in a highly structured fashion as we've adopted, looking at every single case, making sure we've applied an algorithm, making sure that we've addressed the categorization is very, very different than sort of saying, well, we're kind of doing it. Yeah, we believe in these principles. We sort of do that when these cases arrive. One of the main things I would say that has changed for us in terms of communication is that our communication has dramatically improved for those cases where it's not a compensation issue, but it's just an important patient communication issue. As you'll see from the data, the majority of our cases that we are putting through our algorithms don't end up in the bucket where we are exploring compensation. They end up in a bucket where there's an unanticipated outcome, something certainly the patient didn't happen, but we also don't feel like it could have been prevented. In those cases, under our program, patients get a full explanation until they entirely understand what happened. And that, I think, is something our pilot institutions are doing much better than they used to. I think that may have been the source of a lot of our claims. This is speculation because the data is still coming in, but a lot of the claims we've seen are coming forward because someone has an incomplete understanding of what was the cause of their harm, and they did not get the explanation that they needed in a timely way when the harm event occurred, and so now they're coming forward with a claim. That claim may not be defensible in the end, but certainly there's still a tremendous amount of emotional trauma and intensive application of resources that could be avoided by better explanations. And I think that's one of our benefits. So, summarizing, what are some of the things that have helped care succeed in our institutions? One is leadership buy-in. Some of these things you'll see in the checklist for new sites that we've developed and you can get through the Macrame website. But leading that list is the fact that there has to be C-suite level endorsement, vocal and visible for moving ahead with these kinds of questions. There needs to be board level involvement. There needs to be leadership of the medical staff involvement. And I think all of our pilot institutions very formally took this program and its launch to those entities for approval and make sure that those entities continue to voice their approval as we move along. It requires a baseline culture of safety. I don't think this is something you can import into an organization unless you are confident that the culture is there that's going to support this kind of activity. It requires some staff. I think in our larger institutions have a dedicated program manager to really coordinate the program and make sure things are happening. Beyond that single staff person, though, we have used our standard patient safety risk management programs. It requires some new processes for the folks in those departments, but our belief is the best model is to do this as an embedded part of those programs. And finally, it requires some support for clinicians in the form of formal peer support programs. I think this has been an underappreciated area and something that, at least in my institution, we are ramping up and getting better at supporting our clinicians in these kinds of settings. And then also patient resources. We make use of some of the unique resources we have in Massachusetts, such as MITSS, to support our patients and our physicians. And it's great to have a referral source outside the institution for that support as well.